Welcome back to Studious. Today, we continue our community medicine series with a session that sits at the very heart of the discipline, the epidemiological blueprint for disease control and prevention. If the previous session gave us the structural map of how health systems are organized, today's session gives us the strategic framework for how those systems actually fight disease. The central question of this session is one of the most important in all of medicine. How do we analyze disease in a population, understand what drives it, predict where it will go if untreated, and then intervene at precisely the right point to stop it? The answer unfolds across three interconnected frameworks. First, the three-level hierarchy of disease control, from managing a condition to eliminating it to eradicating it entirely from the face of the earth. Second, the epidemiological triad, the fundamental model of causation in which every disease is the product of an interaction between a specific agent, a susceptible host, and a permissive environment. Third, the natural history of disease and the four-level prevention framework, primordial, primary, secondary, and tertiary, that maps a targeted defensive strategy onto every stage of a disease's progression. Let us begin.
The public health ambition for managing any given disease is not uniform. It exists on a spectrum defined by three ascending levels of success. Level 1 is disease control. The objective at this level is to reduce the incidence of new cases, shorten the duration of illness, reduce the risk of exposure, and minimize the effects of disease within a defined population. Critically, control does not mean the causative organism has been stopped. It is still actively spreading. Control is localized and ongoing management, not elimination. The classic example is seasonal influenza. Every year, public health systems deploy influenza vaccination campaigns, antiviral treatment protocols, and surveillance systems to reduce the burden of flu, but the influenza virus continues to circulate globally. Level 2 is elimination. The objective escalates to completely interrupting disease transmission within a defined geographic region. The causative organism may still exist somewhere on Earth, but its transmission chain within the target region has been broken. The poliomyelitis situation illustrates this perfectly. Poliovirus transmission has been eliminated from the United States, the Americas, and most of the world, yet residual wild poliovirus transmission persists in a small number of countries, meaning global elimination has not yet been achieved. Level 3 is eradication, the ultimate public health victory. The complete extermination of the causative organism from the entire planet, rendering further prevention or control unnecessary. As of today, only one human infectious disease has been globally eradicated: smallpox, officially certified by the World Health Organization in 1980, following the last naturally occurring case in Somalia in 1977.
Before we can prevent disease, we must understand how it arises. The epidemiological triad is the foundational conceptual model of disease causation, representing the interaction of three essential components. The first component is the agent, the biological or physical catalyst that causes disease, the seed that seeks to enter and multiply within a susceptible host. The second component is the host, the susceptible human being, whose individual characteristics determine the outcome of exposure to the agent, the soil in which the seed lands. The third component is the environment, the external conditions, physical, biological, and psychosocial, that either facilitate or prevent the agent from reaching and establishing itself within the host. Disease does not occur from any single component in isolation. It occurs only when all three are present in the right configuration simultaneously: a sufficiently virulent agent, a sufficiently susceptible host, and an environment that facilitates transmission. This model has profound practical implications for disease prevention. If any one of the three components can be sufficiently disrupted, the agent destroyed or attenuated, the host's susceptibility reduced through vaccination or improved nutrition, or the environment modified to block transmission, the disease triangle collapses and disease does not occur. Every public health intervention ever devised can be categorized as acting on one or more of these three components of the triad.
The agent component of the epidemiological triad encompasses a far broader and more diverse range of threats than just infectious microorganisms. Understanding the full taxonomy of agents is essential for designing appropriate prevention strategies. Biological agents, bacteria, viruses, fungi, parasites, and helminths are the most familiar category, responsible for the classic infectious diseases that have shaped human history: tuberculosis, malaria, HIV, cholera, and COVID-19. These are the invisible threats that traditional epidemiology was built to combat. Chemical agents encompass the toxicological threats of smoking, alcohol, ingested poisons, pesticides, heavy metals, and occupational chemical exposures. The direct causal link between tobacco smoking and lung cancer, cardiovascular disease, and chronic obstructive pulmonary disease is one of the most robustly established agent-disease relationships in all of medicine. Physical agents cause injury through energy transfer, trauma from blunt force, radiation exposure from nuclear sources or excessive medical imaging, fire burns, and frostbite. Nutritional agents include both undernutrition, protein energy malnutrition, vitamin deficiency diseases such as scurvy, rickets, and pellagra, and overnutrition, including the excess caloric intake and sedentary lifestyle driving the global epidemic of obesity and type 2 diabetes. Mechanical agents cause injury through kinetic forces, crushing injuries, tears, sprains, dislocations, and the repetitive strain injuries of industrial and agricultural work. Social agents, poverty, illicit drug use, social isolation, domestic violence, and unhealthy lifestyle norms represent the non-biological drivers of disease burden that social medicine specifically addresses.
The host and environment components of the epidemiological triad each carry multiple variables that determine whether agent exposure results in disease. Understanding these variables is not merely academic. It is the basis for identifying high-risk populations and targeting preventative interventions where they will have the greatest impact. Host variables, the characteristics of the soil, operate across 4 major domains. Demographic variables, including age, sex, and ethnicity, shape intrinsic susceptibility. Neonates and the elderly have less robust immune responses. Males and females differ in their susceptibility to many conditions due to hormonal and anatomical differences. Certain ethnic groups carry higher genetic risk for specific diseases. Biological variables, including genetic predispositions and specific blood group associations, affect susceptibility to conditions ranging from sickle cell anemia to infectious diseases. For example, individuals with blood group O have significantly higher susceptibility to cholera, while those homozygous for the sickle cell trait have natural protection against Plasmodium falciparum malaria. Socioeconomic variables, including marital status, occupational hazards, educational level, and poverty, powerfully influence health outcomes through their effects on nutrition, healthcare access, occupational risk, and stress. Lifestyle variables, including physical exercise habits and nutritional choices, directly modulate metabolic health, immune function, and risk of chronic disease. Environment variables operate across physical, biological, and psychosocial dimensions. Air quality, water supply, climate, housing, surrounding pathogens and vectors, cultural values, health beliefs, and educational systems all shape the epidemiological context within which agent-host interactions occur.
Having established the triad that causes disease, we now confront the most important conceptual baseline in all of preventative medicine: the natural history of disease. The natural history of disease is defined as the evolution of a disease process over time, from the very earliest interaction between agent, host, and environment, through all subsequent stages of biological progression to the final outcome of either recovery, disability, or death, in the absolute absence of any treatment or prevention. That final clause is critical and must be memorized precisely. The natural history describes what the disease does when left entirely to its own biological course. It is the untreated, uninterrupted pathogenic trajectory, the default outcome if medicine and public health do not intervene. Why is this concept so important? Because it establishes establishes the baseline against which all interventions must be measured. It identifies the precise sequence and timing of a disease's progression, the window of opportunity for early detection before symptoms appear, the critical period during which treatment is most effective, and the point of no return beyond which irreversible damage has been done. Without knowing the natural history of a disease, a public health program cannot design rational prevention strategies, identify appropriate screening timelines, or evaluate whether an intervention has actually changed the disease's course. The natural history is the map. Prevention is the act of rerouting the journey.
The natural history of disease unfolds across two distinct phases, divided by the critical event of agent entry into the host. The first phase is the pre-pathogenic phase, the period before the agent has entered the human host. In this phase, the disease does not yet exist within the person. However, the conditions for disease are being assembled. The agent exists in the environment, the host is susceptible, and the environmental conditions are facilitating their interaction. The triad is active, but the threshold of entry has not yet been crossed. This is the phase during which primordial and primary prevention interventions have their greatest effect. Because the agent has not yet invaded, the disease can still be prevented entirely. The critical pivotal event is agent entry, the moment at which the causative organism or insult crosses the biological barrier of the host, entering the body and initiating the pathogenic process. Once this threshold is crossed, the pathogenic phase begins. The first stage of the pathogenic phase is the incubation period, the interval between agent entry and the appearance of clinical symptoms, during which the agent multiplies internally and physiological changes are accumulating, but the host remains asymptomatic. This subclinical window is the golden opportunity for secondary prevention, early detection before the person feels sick. As internal changes accumulate to a critical threshold, clinical onset occurs. Physiological changes manifest as recognizable signs and symptoms. The patient presents for medical care, and formal diagnosis becomes possible. From this point, the disease may progress to recovery if treatment is effective, to permanent disability if irreversible organ damage has occurred, or to death if the condition overwhelms the host's defenses.
To make the prevention framework concrete and clinically memorable, the progression of type 2 diabetes mellitus provides a near-perfect illustrative model because it unfolds slowly and predictably through all 4 stages of the natural history, giving prevention interventions a clear and well-mapped window of opportunity at each stage. The disease journey begins at the stage of normal risk, a completely healthy individual with poor lifestyle habits, a sedentary lifestyle, a high-calorie processed food diet, poor sleep, and chronic psychological stress. At this stage, there is no obesity, no insulin resistance, and no pathological process. Prevention here means preventing the risk factors themselves from developing. The journey escalates to elevated threat as metabolic disruption begins. The individual becomes overweight or obese, and the body's insulin signaling pathways begin to show signs of strain. Visceral adipose tissue expands, inflammatory cytokines are released, and peripheral insulin receptor sensitivity declines. No formal diagnosis of diabetes exists, but the triad is now actively engaged. The next stage is initial damage, the pre-diabetic state. Fasting blood glucose is elevated above normal, but below the diagnostic threshold for diabetes, typically between 100 and 125 milligrams per deciliter. Beta cell function is declining. The early physiological lesions of diabetes are quietly accumulating. This is the critical early detection window. Finally, advanced failure represents full, clinically manifest type 2 diabetes, leading to the cascade of systemic complications. Diabetic retinopathy threatening vision, nephropathy progressing toward renal failure, peripheral neuropathy causing foot ulcers, and macrovascular disease causing myocardial infarction and stroke.
With the natural history mapped and the diabetes blueprint established, we can now deploy the 4-level prevention framework with precision. Primordial prevention is the most upstream and most powerful level of defense, and it is the level most frequently overlooked in clinical medicine education. Primordial prevention does not wait for risk factors to develop. It prevents the risk factors themselves from ever arising in a population group. Applied to the diabetes model, primordial prevention operates before obesity occurs through health education campaigns, urban planning that creates walkable neighborhoods, taxation policies on sugar-sweetened beverages, regulations limiting the marketing of unhealthy foods to children, and school curricula that establish healthy lifestyle norms in the next generation. The measurable reduction in cardiovascular disease mortality in Finland following the North Karelia Project, a population-wide program initiated in 1972 that targeted dietary fat intake, smoking, and physical activity at the community level, is one of the most celebrated examples of primordial prevention in public health history. Primary prevention operates at the pre-pathogenic phase, after risk factors exist, but before the causative agent has successfully entered and established itself in the host. The action of primary prevention is to remove the possibility of disease entirely before onset by intervening in the agent-host environment interaction. Tactics include vaccination, which renders the host non-susceptible, safe water supply, which removes the agent from the transmission route, use of insecticide-treated bed nets, which interposes an environmental barrier between the anopheline vector and the human host, and smoking cessation counseling, which removes the chemical agent from the exposure pathway.
When primordial and primary prevention have not stopped the disease from entering the pathogenic phase, the second and third lines of defense come into play. Secondary prevention targets the early pathogenic phase, specifically the subclinical incubation period, when pathological changes are underway but the patient is not yet symptomatic. The objective is to halt the progress of the disease at its initial reversible stage before it causes significant damage. Applied to diabetes, secondary prevention means detecting impaired fasting glucose or impaired glucose tolerance, the pre-diabetic state, through population screening of high-risk individuals and immediately implementing structured lifestyle interventions or pharmacological treatment to reverse the progression before full diabetes develops. The landmark Diabetes Prevention Program clinical trial demonstrated that intensive lifestyle intervention in pre-diabetic individuals reduced the incidence of progression to type 2 diabetes by 58%, and that even modest intervention with metformin reduced progression by 31%. Early detection has two compounding benefits. It shortens the total duration of disease in the population, thereby reducing prevalence, and it prevents progression to the severe complications that consume the greatest healthcare resources. Tertiary prevention targets the advanced clinical stage, when return to normal health is no longer possible, and the goal shifts from cure to management, rehabilitation, and prevention of further deterioration. Applied to severe diabetes, tertiary prevention encompasses intensive glycemic control to slow progression, regular ophthalmological screening to detect retinopathy before vision loss occurs, podiatric care to prevent diabetic foot amputation, renal function monitoring, and cardiovascular risk management. The focus is on maximizing functional capacity, preventing complications, and supporting rehabilitation and social reintegration.
This final slide draws together everything we have built today into a single synthesis arc, the complete integrated picture of how community medicine dismantles the natural history of disease by mapping strategic defenses onto every point along its timeline. Reading from left to right across the arc, at the level of risk factors in the pre-pathogenic phase, primordial prevention intercepts the development of harmful lifestyle factors before they take root in the population. As the triad assembles and exposure begins, primary prevention blocks the agent from successfully entering and establishing itself in the susceptible host. As the pathogenic phase opens and subclinical disease begins its internal progression, secondary prevention, through early diagnosis and immediate treatment, halts the advance before clinical disease manifests. As the disease progresses through clinical onset to the advanced stage, tertiary prevention prevents disability, eliminates impairments, and delays death through rehabilitation and complication management. Each prevention level corresponds precisely to a defined stage of the natural history, and each requires a different tactical approach with different tools, different actors, and different evidence bases. The underlying principle uniting all four levels is that disease progression is not inevitable. It is interruptible at every stage.
if we know where we are on the natural history timeline and deploy the right intervention at the right moment. By mapping strategic defenses onto the natural chronology of disease, community medicine transforms what would otherwise be inevitable decay into manageable, preventable outcomes. Please like this video, share it with your classmates, leave your questions in the comments, and subscribe to Studious for the next episode in this series.